Welcome everyone, and thank you so much for joining our webinar. Today we have Doctors Zara Cooper and Elizabeth Lilley presenting on challenges in palliative care and the surgical patient. Just a couple of items before we get started. We ask that you please submit all questions for our panel to the Q&A feature, which is a button at the bottom of your screen. And if any questions that come up are more technical, like if you're having trouble hearing, we ask that you please use the chat feature and we'll do our best to answer all of those. Today we'll pause periodically throughout the webinar to address questions, so please post your questions as they come up. And just a reminder, all of our attendees are muted and video cannot be turned on. Also on our panel today is Dr. Christine Ritchie, co-chair of the PCRC and representing the PCRC Executive Committee. So I think we'll like to get started, and I'll ask Dr. Ritchie to please formally introduce our speakers.
Greetings, everybody. We're so delighted that you're here with us today and get to hear this incredibly exciting talk that we're going to be hearing from both Dr. Zara Cooper and Dr. Liz Lilley. So most of you probably know Dr. Zara Cooper. She's really an important member of our community and field in palliative medicine and the intersection between palliative medicine and surgery. She is the Kessler Director of the Center for Surgery and Public Health at the Brigham and Women's Hospital. She's a trauma surgeon, a nationally recognized health services researcher, and most of her work focuses on that intersection between surgery, geriatrics, and palliative care. She holds numerous federally funded grants, has over 150 peer-reviewed manuscripts, has mentored many trainees and junior faculty, and is a leader in several academic societies. She's also, very importantly, the daughter of Dylan, who is, the mother of the daughter of Dylan, who's 10, and wife to John, who is a contemporary artist and activist. Dr. Elizabeth Lilley, Liz Lilley, is a hospice and palliative medicine fellow at Massachusetts General Hospital and the Dana-Farber Cancer Institute, and she is a recent graduate of the General Surgery Residency Program at Brigham and Women's. She completed her undergraduate studies at Lafayette College and then earned a master's of public health at the Mailman School of Public Health at Columbia University with a focus on history, ethics, and health policy. Not many surgeons that you hear with that kind of background. She completed her medical studies at Rutgers, Robert Wood Johnson Medical School, and during her research years, Dr. Lilley was an Arthur Tracy Cabot Fellow at the Center for Surgery and Public Health, where her research focuses on palliative care needs of surgical patients. And Dr. Lilley has had the good fortune of working with Dr. Cooper. So together, they're going to be talking with us about challenges in palliative care and the surgical patient.
Thank you, Christine. I'm really excited to be here. I love this program and I love the role that this program has in the community, and I'm delighted to talk with everybody about palliative care research and surgery. I think there are some unique challenges that we'll go over. Dr. Lilley and I are hoping that this conversation will be interactive, and so we encourage you to ask your questions as we go along. I think that there's plenty to talk about. Liz is controlling the slides, so I'll ask her to go to the first slide, or I guess the second slide. Thanks. So I think one question that comes up, particularly in the palliative care community, is why surgery? Obviously, palliative care has its roots in cancer care and has expanded to chronic illness, but the intersection of surgery and palliative care is poorly understood and is often under-recognized. But you know, in fact, the average American will have 9 surgical procedures in their lifetime. 1/3 of hospitalized surgical patients are older adults. Surgery is frequently the last stage of treatment for chronic illness. If we think about kidney disease and transplant, if we think about chronic heart failure and VADS, if we think about diabetes and peripheral vascular disease, cardiac disease related to coronary artery disease. You know, you can see that in all of these places, surgery plays a critical role in the treatment of chronic and serious illness. And then frequently we take care of patients who have cancer at all stages of their illness. Many times we're the first doctors that they see once they've received their diagnosis, no matter what stage. And then frequently we we do procedures, palliative procedures, as they progress in their disease. 10% of surgery occurs in the last month of life, and in fact, the most common time for individuals to have surgery is in their last week of life. Surgery also plays a huge role in hospitals and health systems. Frequently, we are the economic drivers, particularly for small hospitals, and surgical care is associated with 1/25 of the gross domestic product, and that number is expected to increase as the population ages. So surgery is critically important to the health, well-being, and the serious illness care of our patients, as well as the economics of healthcare. Next slide. So I do think that within healthcare, the surgeon-patient relationship is a special one. I think we all take care of our patients very seriously. I think we all have a responsibility and fiduciary relationship with our patients. But I think that in surgery, there is this moment where the patient gives you complete control over their body, their soul, and their well-being when they trust you to take them under anesthesia and then to operate on them. And it's different than giving somebody a prescription that they can decide whether or not they want to fill. And so some have described this relationship as a covenant, where it becomes very personal to the surgeon and to the patient that when I agree to operate on you, it means that I agree to do whatever it takes to get you through that operation. And I think for non-surgeons, that can be a very difficult relationship to negotiate and to understand, particularly when complications arise, when difficulties arise after high-risk surgery, because surgeons often seem irrational or irresponsible, or sometimes being very, very selfish and self-centered in their approach to their patients, because it seems like they're willing and wanting to do treatments to their patients that are overly heroic or seem extreme. But part of this is because of the psychology of that relationship. And I think in the elective setting, if you look at this picture, although this person looks like they're in the hospital, patients, you meet them when they're at their best. Everybody is often putting their best foot forward. The referral to a surgeon is often within the context of referral from another provider, whether it be a primary care clinician that the patient knows very well, an oncologist that they have a relationship with. And that treating provider has often, set the stage for, you need surgery. This is somebody who's going to fix you. And so surgeons and patients kind of put their best foot forward because everybody wants this to work out. So, somewhat cynically, I sometimes say that this is like a first date. But what that means is that, when you meet the patient and the family, you see them almost at the best that they can be. And so that certainly, influences and informs your treatment of the patient during their hospital course. This also makes the informed consent process fraught, because sometimes it can be difficult to engender confidence when you're going through all of the possible terrible things that could happen during surgery. And at the same time, it's important to recognize that the patients are often unable to digest and hear some of the more detailed clinical information that we have to transmit when we're talking about complications. So for example, one of the things that I talk about is that I may, as a surgeon, explain to a patient and their family that after a high-risk procedure, I expect that they're going to be in the intensive care unit for a few days. Maybe they need to be on a breathing machine. They might need to be have a feeding tube that goes through their nose for a few days while they're not able to eat or drink by themselves. They'll have a catheter in their bladder, etc. But if you've never been to an ICU, if you've never seen any of those things, it can be very hard to really digest and conceptualize what that means to your well-being, what that means to your autonomy. And as a family member, it can be very hard to imagine what that would look like. And so even in situations where those things have been described, it can be, it can create conflict and misunderstanding in the post-operative time. So those are some of the challenges in dealing with patients and surgeons in the elective setting. What I will say is that, I think that where palliative care can be very helpful is that we are experts at communication, we are experts at goal setting, and so much of this is integral to shared decision making. and to the informed consent process. And there's a lot that surgery can learn from palliative care and how to do these things better. Next slide. As Dr. Ritchie mentioned, I'm a trauma and acute care surgeon, and so this is where I live. I went into surgery because I'm an adrenaline junkie. I like the rush of taking care of acute problems. But it often means that I'm taking care of people when they are really close to death, and my job is to rescue them. Increasingly, I take care of older adults who have injuries and traumas and may be near the end of life, anyway. And so that can certainly complicate describing trajectories and prognosis. From a research standpoint, this can make things complicated because obviously this is an unexpected event. In this setting, as you can imagine in this picture, it's very hard to talk about goals and values when the underlying assumption is that save a life at all costs. And so again, there's opportunity for research and communication. But also trauma in particular is associated with a great deal of disability, with functional decline, often with lifestyle changes, with change in domicile. And so all of those things can really affect patients' quality of life. And so when we think about, the transition of palliative care, as, we think about how we're transitioning away from end-of-life care, really to thinking about a more holistic approach to care and survivorship. Trauma and acute care surgery is really a natural partner for palliative care. And within the surgical community, I think it's fair to say that many of us who are boarded in hospice and palliative medicine are trauma and acute care surgeons, because we use this in our day-to-day surgical practice and also in our critical care practice when we're intensivists. For the rest of the talk, we really wanted to take our audience through our experience in kind of making the case for palliative care. When I started in this, there were a few of us, and I stand on the shoulder of giants, Ann Mosenthal and Jeff Dunn, and others who really started the movement within the American College of Surgeons. But there weren't that many of us who were doing this, and so I have spent about a decade really trying to make a case for palliative care with my surgical colleagues, and then also with my palliative care colleagues, to make the case that the palliative care is relevant. And so we've had lots of experience in generating data and writing manuscripts, but there are unique challenges in primary data collection and secondary data collection that Dr. Lilley will review, and I look forward to discussing with everybody during the talk. So Liz, I'll turn it over to you. Thank you.
So I'm really excited to be here and talking to you about some of the research that I've done with Dr. Cooper. And so when we started to think about how we could make the case for palliative care and surgery, one of the places we started was looking at what's been done in other fields, what has worked in oncology or in nephrology. And one of the things that we first tried was using the surprise question. In one of our studies, we used the surprise question for patients who were coming in with an emergent surgical condition. And we asked the emergency general surgeons or surgical senior residents if they would be surprised if patients died in the next 12 months. Similar to what has been found in other studies, the surgeons were able to identify patients who may need palliative care using this as a measure. What was really interesting is where things were different, where palliative care and surgery looked different from these other studies in nephrology, general practice, or oncology. Our patients had a 39% mortality rate at 12 months. And this was all patients who came in with an acute surgical condition through the emergency room. This included patients with gallbladder disease or appendicitis. And so our mortality in all of these older patients really approaches patients with stage 4 cancer. Our surgeons overestimated mortality. About 60% of the responses to the surprise question were no, I wouldn't be surprised. And I think that this really shows how sick this patient population is, but also that it is potentially a decision point, a point at which we can identify which patients may need additional help. It also showed us that this is maybe not a feasible screening tool for us to use in our surgical patients, because 60% of our patients would be using this criterion eligible for palliative care evaluation. Using this idea that, well, the surgeons maybe are overestimating, our other thought was, could we engage or activate patients? This study was a multi-site study looking at 5 different hospitals using a question prompt list. The goal of our intervention was really to see if we could engage patients to ask questions for themselves in the preoperative period. So for those elective patients who were coming in with a major oncologic condition or vascular condition, they were given a question prompt list before their appointment with the surgeon, as well as a letter endorsing use of this. And so what this looked like was a list of questions that could be potentially asked in that initial appointment. This was developed from the University of Wisconsin by Gretchen Schwarzy, and she led this study, which was an incredible undertaking. The study included patients who were 60 or older who had a major comorbidity, and they received this to look through before their appointment for half of the patients in the study. What was interesting was that we didn't find that this really made a difference. There were no differences in the number of questions that were asked in the appointments. There was no difference in the perception of communication with their surgeons. They didn't have differences in terms of well-being or regret during their follow-up period. Another interesting point was that surgeons really supported this. I think there's sometimes a misperception that surgeons may be resistant to these kinds of communications, but the surgeons' reflections were that this was great. This really engaged patients. They thought these were really important questions that they tried to talk about in the preoperative period. Nonetheless, we didn't find what we really were hoping or expecting to find. And so looking at these experiences in research made us think, why is that? Why are we not finding this to be an incredibly helpful tool? Part of the problem that we identified was that some of our patients are just too healthy, or they seem too healthy in their initial period. They don't really know who is going to have a major complication, who's going to really have needed to have this great conversation. And so it was hard to make patients understand that this was really relevant to them. In this and our other experiences with using primary data to try and make our case for palliative surgery, we identified a few challenges for primary data collection. One is recruitment. Recruitment is challenging because there's a lot of variation from discipline to discipline. So emergency general surgery is very different from the elective setting. There's also differences from hospital to hospital. Some of these patients may see their surgeon for the first time and be in the operating room within 1 to 2 weeks. Other patients or patient populations, they'll have a longer relationship prior to their operation. So determining when to have our intervention can be challenging. Another recruitment challenge is that some of these patients are just really not sick enough. We don't know who is going to have a problem in the postoperative period. And another challenge is some of these patients are just too sick. When we think about a palliative patient population, patients who have major disease or who have poor prognosis going into a palliative operation, some of them are just not interested in being recruited to a research study. This has also been an issue with attrition. The patients who have the worst outcomes after surgery, high morbidity and mortality, or are debilitated or discharged to rehabs or nursing homes, those are also the patients that it's really hard to follow up. So the sickest patients are the ones that we end up losing in our follow-up data. And I thought a very interesting finding from Dr. Schwarze's study was the ceiling effect, this unique relationship that Dr. Cooper spoke about. When patients were asked to rate their perceptions of communication with their surgeon, in both groups, the ones who received the question prompt list and the ones who didn't, there was really incredibly high ratings of that communication. And so these metrics that we are using are not necessarily studied in a surgeon population. So they may not be valid for use for this research. Because of these challenges with primary data collection, we've also been using administrative data to try and make our case for palliative surgery. When we talk to other surgeons and we're trying to figure out where we can make the difference, where we can really deliver the evidence that would make sense to the other surgeons, malignant bowel obstruction came up as one of the most common and most distressing consults that surgeons face. And so using administrative data, we looked at survival, healthcare utilization, as well as the end-of-life care that patients receive after a malignant bowel obstruction admission. When we think about patients who have malignant bowel obstructions, regardless of what treatment they have, we thought that end-of-life care was a really important metric to use. Most surgery research looks at things like 30-day mortality or perioperative complications, but really focus in on the surgical admission or the first 30 days. And with these patients who have a incurable cancer, that just didn't seem to be the right metric for us. So instead, we looked at metrics that have been used to show high quality end-of-life care for patients with cancer. And so this was a bit of a shift in how we were thinking about surgery. Comparing surgery versus patients who had venting G-tubes or medical management, we found that after the first bowel obstruction, survival was short, regardless of what treatment that patients had. In fact, 65% of all comers died within the first 6 months. And this really supports our use of end-of-life outcomes. And so then when we look at end-of-life outcomes for these patients, we compared surgery, venting gastrostomy tube, and medical management. Now, certainly with administrative data, there's limitations. These patients are not being randomized, but this study still is able to provide us with information that we didn't have before on things like readmissions, ICU stays, hospice, dying in a hospital. And when we think about the patients that we're seeing and having these conversations about decision making with, very often these are the things that they most value. So administrative data can be an ally in that way, in letting us sort of paint a picture of what end-of-life care may look like after a procedure. In another study, we tried to figure out, for patients who are having these large, major abdominal operations in the emergent setting, what are the things that are predicting mortality? A lot of this is not necessarily something that you can find from billing or claims data. This study used the HRS data linked to Medicare to identify predictors of mortality up to 1 year later. Now, the benefit of HRS data is that it gives us things that we really couldn't otherwise find, things like healthcare utilization, functional status, functional decline. And using this data, we were able to find that really the largest predictor of mortality up to 1 year after emergency surgery is still surgical complications. Even after we examined and controlled for differences in age, comorbidities, patients' ability to carry out activities of daily living, surgical complications was the strongest predictor of mortality. At 1 year, the mortality was 34%, which is about what we had seen in our study at Brigham and Women's. And these patients coming into surgery, who, regardless of what they look like before, what happens during the surgical admission is important. This made us start to think that surgery is a potential inflection point, and the patient's comorbidities and prior disease state is in some ways no match for what can happen in the operating room. The next study that one of the next studies that we did was looking at traumatic brain injury. What was interesting to me and Dr. Cooper, and where we sort of jumped into this study, was thinking about, besides patient factors, besides surgical factors or even surgeon factors, what else can influence someone's outcome? And I live in Boston. We are in Boston, where there are 5 large trauma hospitals within a few miles of each other, all level 1. And it started making me think, what if a 80-year-old woman fell down and hit her head and had a large brain bleed? And what if that happened in Back Bay or in Brighton? Would the location where she lived, and really the location where she received care, would that have a bigger impact on the care that she received than the patient herself? In other words, does it really matter what the patient wants versus what the providers are willing to do? To test this, we looked at hospitals. We used this idea of 30-day mortality. So we said, fine, we'll rate the trauma hospitals based on high or low mortality, where low mortality hospitals with low 30-day mortality after major trauma, were considered to be high-performing hospitals. And so what we found that was interesting is the hospitals that had lower mortality rates also had higher or better end-of-life care. In other words, despite the fact that patients died at lower rates, the patients didn't receive any more aggressive care than at other hospitals. In fact, the patients who survived had less aggressive care, despite similar traumatic severity. We found that patients who were treated at hospitals that had low mortality rates, who then died within a year after surgery, those patients were more likely to receive hospice, were less likely to be in a SNF or an LTAC, were less likely to have things like tracheostomies and PEGs. And so this really goes to the point that it's not just about what the patient wants, but also about what the culture of the hospital is, what the teams are doing to embrace or not embrace palliative care and hospice. I know we wanted to pause to take some questions. I'd be happy to do that now. I'm sorry, I can't see any questions in the chat.
This is Christine. I have one question for you, and that relates to this study where you looked at high, quote unquote, high quality hospitals and their end of life care. Were you able to get a sense, I know you were using claims data, were you able to get a sense at all about the nature of the care that they received in the hospital in terms of burdensome treatment?
Yeah, so that's actually a really great question. So we did look at the use of life-sustaining treatments. We looked at dialysis, blood transfusion, tracheostomy, and PEG placement during the hospital stay. And for things like blood transfusions and dialysis, whether patients had been intubated, they were similar, really based on they really were more related to the trauma severity as opposed to the hospital. And that made sense to us. Alternatively, a PEG or a trach was less likely to be performed on any patients who lived or died in hospitals with lower mortality. And so part of it is we're not quite sure why this is happening. We don't think that it's that the patients who are getting trachs are dying because of the trach, but we think it's more a holistic view. There have been some studies that that thought that maybe hospitals or ICUs where patients were being provided higher quality end-of-life care, the patients may die sooner, but there is no increase in mortality. And so this would, I think, be explained by a similar phenomenon. Okay. So next, when we think about administrative data, I think that there's a lot of challenges to administrative data that we have discovered in our work. One of the challenges is that there's really a lot of limitations to the use of claims codes, particularly for things like palliative surgery. For the study that looked at malignant bowel obstruction, there is no billing code that says malignant bowel obstruction. Sorry, I'm having a computer problem. Okay. There's no claim code for a malignant bowel obstruction, so we needed to be a little bit creative. We needed to say, okay, well, patients with stage 4 cancer, incurable cancer, patients who are admitted with a small bowel obstruction, we would consider that to be a malignant obstruction. When we think about our procedure codes, there is no code for a venting gastrostomy as opposed to a feeding gastrostomy. So when we were trying to determine whether we had a patient getting a palliative venting peg, we had to make the leap of saying, well, a patient who has metastatic cancer, who is admitted for a bowel obstruction, if they have a peg placed, it's certainly not going to be for feeding, because you wouldn't feed someone who is obstructed. And so we did have to validate those definitions. We had to use our own hospital data sets to determine whether those were accurate. But this is a major challenge to actually studying palliative procedures, palliative surgery, or patient populations that are the highest risk. Another barrier that we faced is patient experience, outcomes that really are important to patients near the end of life. When we were studying when we were looking through what studies have been done really in surgery, the outcomes that are very common are just not relevant to patients at the end of life or to assess a palliative outcome. And so using end-of-life outcomes from the National Quality Forum, using things that have been studied in patients with stage 4 cancer, that was helpful to us, but it doesn't really give us a lot of information on things like symptom burden, which is certainly important, particularly when assessing palliative procedures. And finally, a lot of the research databases, particularly in surgery, are focused on 30-day mortality or care received in 30 days, or even just during that one hospital stay. And so when we think about longitudinal outcomes, because many patients survive the hospital stay only to die within the following few weeks or months, some of the administrative data that is available and most frequently used for surgical research is just not going to cut it. In trying to overcome some of these challenges, we started looking to other solutions, and we're very fortunate to have Dr. Charlotta Lindvall, who may be on this webinar, who does work with natural language processing. And natural language processing was able to address some of these issues. She had developed a platform that allows a search through free text notes. In other words, the clinic notes that you write, progress notes, discharge summaries, operative reports. And the natural language processing program will identify keywords that you select in order to look at more nuanced variables. We tested this looking for venting gastrostomy, venting PEG, malignant bowel obstructions, palliative surgery. And using some of these terms, we were able to identify in large patient data sets, patients who had had palliative procedures or patients who had been considered for palliative procedures and ended up not having surgery. In addition, we were able to look at things that are certainly not readily available in administrative data, like goals of care. The electronic health record also gives us longitudinal data. Patients are seen multiple times during the course of their treatment, day to day in a hospital admission, but also weeks, months, years later. And having access to all of these electronic health record notes allows us to see how patients can change over time and how decisions can change over time. Finally, one of the benefits of using natural language processing is that it's a very low cost, economical solution. The electronic health record data is available. And it's also much more rapid and standardized way to extract things from the medical record. Extracting things from the medical record through chart review, having students or research assistants is incredibly time consuming, whereas NLP is able to identify key terms within notes in a matter of seconds. So using this natural language processing, we started to think, what are the things that we really care about? What are the things that really matter to someone who's considering palliative surgery? And if we're saying that the outcomes that we normally use, like 30-day mortality, are inappropriate, what is really an appropriate metric of good care for someone who's having an operation for symptom relief? And in thinking of this, we started to say, well, these are things that are not easily quantifiable from claims data or even from interviewing patients sometimes. So using NLP, we started to look for things like goals of care discussions, conversations about patients' serious illness and their values and priorities for end-of-life care. We were also able to look at whether code status was clarified, limitations on life-sustaining treatment, or decisions not to have limitations. We looked at palliative care consultations and notes from palliative care, and whether hospice was discussed. We use hospice frequently as a metric of whether end-of-life care is done well, but just because someone doesn't enroll in hospice doesn't mean that it wasn't discussed or considered, or that there wasn't a good reason that hospice was not right for a patient. And so finding that assessment for hospice was incredibly valuable. So using natural language processing in patients who had pancreatic cancer, we were able to identify things like these conversations or these sentences that were embedded in a patient's medical record. The patient feels that time is short and that her body is shutting down. Her goal is to make the best use of each day. Let's cherish it. Alternatively, a patient who remains full code despite having stage 4 pancreatic cancer, identifying that this is aligned with the goals of care is, I think, incredibly valuable when assessing whether a team is doing the right thing. So we identified these keywords and used this keyword library among patients who had pancreatic cancer. And using the pancreatic cancer patient population, we had incredibly high specificity and sensitivity. However, we found that when we applied these same variables, these same keywords to a different surgical patient population, in this case, emergency general surgery, the sensitivity went down. And so from this, we realized that surgery can't be considered just one large field, but emergency surgery is different. And the way that conversations are had, the way the conversations are documented is also different. These differences between different services, even within the same institution, I think are important and give us information about how and why these conversations are being had, and how they're being documented. A few years ago, we worked on developing what we thought would be the most important aspects of a new research agenda. When we looked at palliative care research and where everything has gone in the last several years, there's still a lot of ground that needs to be covered. One of our first priorities was defining outcomes that matter to patients. And I think this is really where palliative care and surgery need to partner in order to answer this question. We need to figure out what things are of value to patients who are having surgery, because certainly the idea that they want to live longer or be free of symptoms is important, but knowing that complications from the operation can cause major changes in function and quality of life. Engaging palliative care to partner with us in researching what patients are willing to go through or not willing to go through is incredibly important. We also need to define outcomes that are valuable after palliative surgery. 30-day mortality, as we have said time and time again, is just not a valuable outcome. When we think about decision-making and communication, more research needs to be done, not only in the preoperative period, but also, as we've seen, surgical complications can certainly alter a patient's trajectory. And therefore, we need to figure out how these communications are happening in real time when complications occur during the hospital stay. And finally, I think that the future of palliative care and surgery really has to be determined based on delivery. Delivery of palliative care to surgical patients is such a challenging problem, and a problem that I'm still, during my fellowship now in hospice and palliative medicine, only beginning to grasp. The differences in the systems, the differences in the way that patients come onto a surgical service, either electively or emergently, but also the cultural differences, the differences between surgeons and palliative care clinicians, I think make it challenging for surgeons and palliative care clinicians to work together at times. And understanding these differences, exploring them, being honest about what is frustrating us, I think will enable us to figure out how we can overcome those challenges in order to improve care for our patients. The next steps. There are a lot of different directions where palliative care research in surgery needs to go. And in order to achieve some of these goals, we need to have funded research. We need to engage surgeons who are interested in palliative care, but also grow interest in surgery among palliative care clinicians. Interdisciplinary research, not just physician to physician, but also nurses, nurse practitioners, chaplains, social work. These are incredibly important, and seeing how these interact in the surgical world, which is quite different from the oncology world that much of palliative care research has been focused on. And there is incredibly sparse data on the community experience. Almost all palliative care research for surgeons has centered on academic centers. So in order to figure out ways that palliative care can be better delivered to all surgical patients, we need to look at what is happening in the communities. I'd be happy to take any questions.
Thank you so much, Dr. Lilley, Dr. Cooper. Let's wait just a few minutes for questions to trickle in. And just a reminder to please use the Q&A feature at the bottom of your screen.
Dr. Lilley, while we're waiting for questions to come in, I wonder if you could, since you've now gone from a surgical residency to a palliative care fellowship, what you have noticed are some of the maybe cultural or language related differences or disconnects between the two cultures of surgery and palliative care.
Thank you so much for that question, because I think that's a question that I have been in some ways struggling with for the past 6 weeks in a way that I really didn't expect. I think that the best way I can describe it is by saying how I viewed surgeons when I was a surgical resident. And as an intern, I really just completely bought into whatever my attendings were doing because they were gods to me. But the more medical knowledge that I got, the more I started to question some of the decisions, question what are we doing when we have this very sick patient who has had a lot of complications? Why aren't we having a conversation about the bigger picture? Why aren't we engaging palliative care sooner? And of course, these questions came up because of my interest in palliative care, but also because I felt that my patients were suffering, and at times I felt like I didn't understand what my surgical teammates, my attendings, my senior residents were thinking. And then when I became a senior resident, when I was a chief, when I felt like these were my patients, these were patients that I obtained consent from, that I spoke to about surgery, that were reaching me on my phone, whose family members I spent a lot of time with and whose bodies I had my hands in. When those patients then had complications where they were incredibly symptomatic, suffering, where mortality was at times inevitable, I couldn't see it. When I was the surgeon, when it was my patient, I just really couldn't see it. And now that I am in a new role as the palliative care team, it's almost an out-of-body experience for me to go into these family meetings, to go into team meetings and hear the surgical team describing what's going on with their patient and what their expectations or hopes or goals are. And with my surgical knowledge, being able to see that a lot of those goals are probably not attainable. And despite their best hopes, some of these patients are going to die. And being able to feel the pain and in a way, having no judgment anymore, because I've been there and I've been out on that limb fighting for a patient. I think that cultural piece, I didn't understand when I was a surgeon, and is the thing that I am finding to be the most troubling to me, being the palliative care clinician, but also the most informative in how to support these teams.
Thank you for sharing that. I think that's really, really interesting and valuable. We do have a question, so I wonder if you could answer the question about how you see surgeons in other specialties, for example, cardiothoracic surgery, how you might imagine them getting involved with palliative care research.
I can take that one. Thank you for this question. I think it's really important. You know, we described that there are nuances between specialties, and I think that the involvement of surgeons in various specialties is really important. There are some cardiothoracic surgeons who have participated with us in some of our work, and there are some cardiothoracic surgeons, for example, who serve on the Committee for Palliative Care and Surgery at the American College of Surgeons. So I think the way to get involved is to identify people who are doing it. If you're fortunate enough to have some palliative care research at your institution, then to connect with those individuals, whether they're surgeons or not. I think one of the beauties of palliative care and palliative care research is how interdisciplinary it is by necessity, as Dr. Lilley described. And I think that that's something that we can learn a lot from as surgeons and as surgical health services researchers. So, I would encourage, and I do encourage surgeons and other specialties who are interested in this work to reach out to people who are doing work that is similar to what they would like to do, and to partner with them. I can give myself as an example. A few years ago, I saw a study that Christine did actually in orthopedic surgery patients. And I reached out to her and said, I think this would be a great study in emergency surgery patients. And so we did it. And so that was a wonderful collaboration that included, health services researchers, geriatricians, trauma surgeons, orthopedic surgeons, palliative care clinicians and researchers. It was really great.
Thanks, Zara. We have another great question here, which is when you think about increasing the interdisciplinary nature of research in this area, what are your thoughts about how to involve rehab clinicians? Physical therapy, occupational therapy, rehab medicine.
Yeah, I think that's a great point, and I would echo what I said about so I think that's twofold. One is an opportunity for other types of clinicians to become involved in surgical research. And I'm so glad to see these questions, because I hope, one of my objectives for participating in this webinar was for that to happen, so that members of other disciplines would consider surgical research when they're thinking about doing their palliative care research. But I think the flip side of that, and this is critically important I think for hospital-based medicine in general, but for surgery in particular, post-discharge care is a black box. And so there's a lot to be done in understanding patient trajectories, quality of life, wellness after surgical care, because, a post-operative visit, your last post-operative visit, maybe 6 weeks after surgery, that ends your surgical care because the wound is healed and, the staples are out or the sutures out or whatever it might be. But the patient is still in the middle of their recovery journey or not. And the work that we've done with you, Christine, and with Amy Kelly and others has really shown that, there's, high mortality or higher than expected mortality for many surgical procedures up to 6 months after surgery, and that, functional recovery takes at least that long, particularly for older adults. So there's a lot of room there for rehab clinicians to really inform how we think about the surgical journey. I hope that answered the question.
Great answer. Thanks so much, Zara. I think that concludes our questions and our time. Thank you so much to both of you for all of your incredible work. It was just very instructive to hear all the great work that you've done, and so much that you've helped reveal around both opportunities and challenges in that intersection between palliative care and surgery. I want to turn it over now to Naomi Galpin, who will tell us about the upcoming webinars. But again, thank you so much, Dr. Cooper and Dr. Lilley, for really giving us incredible thoughts for the future in terms of this research.
Thank you for the invitation. It was great.
Thank you.
Thank you, Dr. Ritchie, and thank you to Drs. Cooper and Dr. Lilley, along with everyone who's joined today. If all of our attendees do go to our website, we have 2 more webinars that are posted for the near future. Next up, we have our digital health SIG leaders, Drs. Jennifer Ports and Carla Washington, presenting on digital health solutions for your COVID-19 research contingency plan. This panel discussion will also include Drs. George Demiris, Abeba Laque, and Stacy Fisher. Then in September, we have another very timely webinar on the NIH Center for Scientific Review, Health Delivery and Methodologies Integrated Review Group Study Section Changes with the Chief of the Center for Scientific Review, or CSR, Dr. Delia Olufokombi Sam. We hope that you join us for those as well. And we'll also be sending out an evaluation where we gather other topics that might be in presenting on. So please take a minute to fill that out. Thank you again to all our speakers and for all of our attendees for joining today. Take care, everyone.